Now next presenter is Dr. Himika Gupta, and she will talk on 3 hits and miss lesson learned in retinoblastoma diagnosis.
Good afternoon, everyone, respected judges. I'm an ocular oncologist based out of Mumbai, and today we'll be looking at 3 hits and a miss that we learnt over the 8-year period of RB work that we've done. So out of 47 patients which were referred as retinoblastoma, 9 were unsure, and out of that 2 were PHPV, 3 were ophthalmos, and 4 were, well, very different, we thought. And we are going to look into these 4 X files. So the first was a 1-month-old, 1 kg child referred from the NICU with this small mass during ROP screening, which looked like a retinal astrocytoma or a hematoma. So we sent her for MRI screening, and there were subepidermal nodules, which was suggestive of tuberous sclerosis. So that was our diagnosis. We decided to wait and watch. The next EUA, the tumor grew, the child also grew, and there was subretinal fluid. Looked like a group D retinoblastoma. So we were quite confused, but because the tumor grew, we decided after tumor board, let's treat it like RB, and we gave her the protocol based management, chemo. She did not tolerate it too well. She had multiple trips to the ICU, but yeah, somehow she made through. And finally, in October 24, the tumor was totally cured. Her genetics turned out to be negative for TSC, negative for RB, but 1 VUS. So here we dealt with this first case, which looked like a tuberous sclerosis, but finally turned out to be retinoblastoma. Case 2 was a 4-year-old child who presented with a sudden onset redness, watering, decreased vision. There was almost a hyphema and a corneal melt. Well, this case had an anterior staphyloma in the inferior part, and there was no other history suggestive of leukocoria or anything. B scan showed the lens which was subluxated into the vitreous, a vitreous hemorrhage, no tumor, and our working diagnosis was endophthalmitis, orbital cellulitis, or perhaps a mascarade. So we treated him with antibiotics and IV steroids and posted him for an EUA, and what we found was on the better eye, on the other side if you can see, there was a small 1.5 dd tumor. So we were actually dealing with a case of bilateral retinoblastoma presenting as a mascarade. He underwent enucleation and implant for a painful blind eye with suspected tumor. We found tumor in his eye, it was RB, and he was treated as per the protocol. The third case was a 9-month-old who presented with squint at 3 months. He was reassured. Then he got leukocoria/yellowish reflex. He was again reassured by the pediatrician. And then when the parents changed the pediatrician, he was evaluated and diagnosed to have Coats disease. He was referred to us for an EUA just in case. And what we found was shocking. Bilateral retinoblastoma, one eye group E, other eye group D. Systemic workup, negative. Genetic testing, negative. So now we were shocked. And the parents were relieved. They said, no, this is not retinoblastoma. Our primary doctor told us this is not RB. So we were more shocked. We said, okay, now what do? We treated him based on protocol and repeated the genetic testing. First time it was the MLPA, multiplex ligation analysis, and now we did the NGS full sequencing, slightly more costly, but we had the answers. It was retinoblastoma. The last case was a 4-year-old who presented with leukocoria elsewhere, had a retinal detachment documented on B scan, no tumor, reassured, sent home, came back after almost 2 years with this kind of a orbital mass. The imaging showed an orbital tumor extending from the eye into the orbit, but not beyond that into the CNS, and the other eye was normal even on EUA. So he was diagnosed to have an orbital retinoblastoma. So AJC staging was T4B N0M0. He underwent protocol-based management, but the pathology showed sheets and cords. No obvious, there were round cells, but not typical of retinoblastoma. There was bony tissue. I had not taken out any bone in this exenteration. So the pathologist said, is this rhabdomyosarcoma? But we went back to the history, there was nothing suggestive of that. Then there was a lot of push and pull amongst various pathologists, lot of stainings were done, and finally it was found that the LIN28 was focally intense, which is more for mesenchymal and medulloepithelioma-like cells. So the final diagnosis in this case was a malignant teratoid medulloepithelioma, and here I would like to acknowledge Dr. Kostomule, who helped us to come back to the final diagnosis. And finally, we treated him. The management was almost the same, so that part was good for us. So to conclude, we realized that, especially with these 4 cases, that examination under anesthesia, primary and serial follow-up, is a good idea, especially under a trained ocular oncologist setup. Okay, and wait and watch can also be an option. Sometimes it helps us to conclude a lot of things. Radiology alone may not be always helpful, and whenever possible, histopathology helps to seal the diagnosis. Thank you so much for your patient listening. We have this annual retinoblastoma event, and here the kids are getting prizes. Thank you.
Yeah, thank you, Dr. Himika. That was quite an eye-opening cases you have got.
Thank you.
Thank